So my name is Abdulaziz Mulaik. I'm an assistant professor for emergency medicine. I'm also a critical care physician. I work at King Saud University in Riyadh. I used to be the program director up until 2 years ago, and then I handed over that heavy weight to someone else to take over and carry on. So what I'm going to talk about today is intra-arrest thrombolytics. We're going to start off by a show of hand, and I really need you guys to be as interactive as possible, okay? I'm going to squeeze it down to 12 to 15 minutes, not more than that. We're going to go over a little bit of articles and literature that talks about this specific topic, few stories, interesting stories, and hopefully you'll get something out of this today. So, show of hand. Who have ever given or administered lytics in cardiac arrest? 1, 2, 3, 4, 5. So that's probably less than, I would say, 5% of the audience, okay? Now, and the question here, does it really work or not? Is there evidence behind it or not? And like most of you guys, whenever I have a cardiac arrest that shows up at my doorsteps, I have those guys singing in the back of my head. Those are called the lytics, and they are an underground hip-hop Canadian group, and they keep singing I'm here," whenever I have a cardiac arrest. But the question is that, does it work or not? So I'm going to start off by the bottom line, and the bottom line basically is what the AHA and the ECC recommended back in 2010. And frankly, they haven't changed the recommendations up until 2015. And their recommendation is, well, for undifferentiated cardiac arrest, administration of thrombolytics is not something that they strongly feel about, okay? So let's be more specific here. For undifferentiated cardiac arrest, intra-arrest thrombolytics is not something that they feel strongly about. They do not recommend it. And that's very important, okay? And there are people who argue against that notion. And we're going to go over a few of these concepts. So, now, the problem is that things are not black and white. They're never black and white in medicine. There's a huge spectrum, so many shades of gray, okay? And that's what creates the uncertainty about a lot of the interventions that we have available. And I'm going to start off by a case. This is true. This is a true story that took place a little over 2 years ago, and I was involved in the care. So I was working a night shift, start at midnight. It's a heavy shift. People lining up. I have, patients lining in the corridors. It's chaotic, and you know how it is. It's just one of those days and one of those nights where you really don't want to be in the emergency. You just want to go home, and as soon as you walk into the emergency department, you can see the parking lot is full of cars, and you say, "Oh my God, and this is not the night." Anyways, so 2 hours into my shift, I hear a commotion just in front of the main door, or it's the ambulance bay. And people are screaming, and they're yelling, and so I'm the emergency physician handling the resuscitation area. So I walk towards the ambulance bay just to explore, to find out exactly what's going on. So there must be something bad going on there. Let me go and explore. So I walk up all the way to the ambulance bay, and I see this guy. He's about in his 40s. He's a young gentleman. He's in 40, 45 years old. He's a worker, so he's an expat. He doesn't speak English or Arabic, so the guys and the paramedics and the nurses are unable to communicate with him. And he's quite agitated. So he was just like doing this and that, and he's sitting and flipping and turning on his side, and he's moaning, and I don't know what's going on with this guy, but there are a lot of people around him, and they're trying to talk to him, and all I see is that he's pointing to his chest, and he's breathing heavily, and he's labored, and I said, you know what, just cut it short, let's take him to the resuscitation and see what's going on. This is not going to go well. So we take him to resuscitation. As soon as we put him on the bed, you know the usual. Hook him up to a monitor, this and that. People are trying to get IVs, and we're trying to talk to him. I said, what's the problem? What's going on? Just talk to us. Let us know. Is it a chest pain? Do you feel short of breath? It was just a mess. Anyway, so 2 minutes into just hooking him up to monitors and trying to get as much as information as we can, and we just managed to get the set of vital signs. His vitals were not that bad. His BP was, pretty much normal. He was a little bit tachycardic at 110, 120. However, he was tachypneic, and his rest rate was way above 40. It was just, he was panting. Oh, that was an interesting thing when you see, and he was clearly uncomfortable. And then his companion came over, and he said, he's diabetic. So fine, his glucose is above 20 millimole per liter. So that's fine, okay. And we hook up to an oxygen monitor, pulse ox, and his oxygen sat is in the 95 on room air. So that didn't make sense. Anyway, so we ordered an ECG. So they're hooking up the ECG leads, and as soon as they hooked up the ECG leads, the guy goes flat. So he goes into a cardiac arrest. Oh my God, that's another. So we started resuscitating him. He came back quite rapidly after a dose of epi and this and that. And then he collapsed again. Another round, and in between, we managed to get that electrocardiogram. Okay, so that electrocardiogram is in between his multiple episodes of cardiac arrest. So, any idea what's going on? I'm sorry? Okay, so you can argue that there's a right bundle branch block. Any other possibilities out there? Would you think that this represent an ST elevation MI of some sort? Okay, so PE, we talked about the S1, Q3, T3. Anything else? We have right bundle branch. Any intoxication? Toxidrome, something that is reflected on electrocardiogram? You're not sure? TCAs maybe? No. Back again to the STEMI. Any of you thought it was there's it's a little bit of ST elevation here. Maybe this is the V4 on the right side. So the cardiology fellow was nearby. So I pull him here, and I pull him over, and I say, look at this electrocardiogram. This guy came in with that story. It was a very sudden onset. According to his companions, he felt short of breath, pointing out to his chest, brought in here within 10, 15 minutes. Lo and behold, as soon as we put him on the gurney, he goes flat, and I get this electrocardiogram. And all I know is he's diabetic and he's 45 years old and he looks like a smoker. Do you think that this looks like a STEMI? He said, what, this ST elevation, I'm not sure. There may be a little bit of elevation, but he agreed that there's a right bundle branch block, so it's difficult to interpret. He said, let's just activate code STEMI. So we did activate code STEMI within a reasonable amount of time. That was the whole thing took about 9 to 10, 12 minutes from the point of entry all the way to the activation, and that discussion happened quite rapidly and promptly. So we activated these code STEMI. He consulted his interventional cardiologist, which turns out to be a professor. So his professor looked at the electrocardiogram and said, just bring him up. So he went to the cath lab, and within a few minutes of him being in the cath lab, I get a call. I said, and the call says, can you send thrombolytics? What? You're in a cath lab and you want thrombolytics? Okay. So by all means, so we send a nurse with the thrombolytics from emergency because it's easier to get thrombolytics from the emergency. We stock it and not from the pharmacy. So this nurse runs all the way to the cath lab and hands over the thrombolytics. Now, so I posted the surveys, and I presented this, actually not me, it was my resident at that time. He presented this case in the grand rounds, in our grand rounds. And we actually, ask a question. What is the most likely diagnosis? So show of hand of you who thought that this was probably a STEMI or the ECG represents some sort of a STEMI. Show of hands, show me hands. Up, 2, 3, 4, okay. So who thought it was a PE off the bat? Oh, interesting, okay. Right bundle branch block. I think a lot of you probably agree on the, okay, so TCA, toxicity, no, not really. Flutter, fib wave, no. Okay, so this is the results of the survey that I've done. And this was posted online on a blog. So I had a lot of people looking at this electrocardiogram asking the same question: what do you think the diagnosis was? And as most of you probably felt, the majority, about 1/3 of the respondents thought it was PE, so 29% of all respondents, and about 24% of them thought it was some sort of a STEMI and might have represented a STEMI. All they had exactly what you had. Now, a small history. So a lot of people thought it might be this or that. Now, I'm going to show you video. Let's hope. It's not working. Is it working from your side? Can you see if it's, no? Okay, so unfortunately, it's not working. So these are the actual cath images, and you can see that he has clean coronaries, okay? But the cardiologist was interested. He wanted to know exactly what was going on, so what he did is basically shooting contrast in the pulmonary arteries, and he had a massive PE. And consequently, what he did a mechanical breakdown of the thrombus, plus intra-arterial injection of thrombolytics, which flow improved across the PA pressures went down. He went to the ICU, stayed there for a few days, and then walked out of the hospital. Okay, so let's move on. So what is the evidence? We're going to skip on this. Okay, so is there physiological consideration? What is the pathophysiological consideration in this? We know that about 50 to 70% of all cardiac arrest or out-of-hospital cardiac arrests are probably caused by PE or MIs. And we talked about the survival rate of all out-of-hospital cardiac arrests is probably less than 10% or around that number. And we have experimental studies that have looked at thrombolytics in cardiac arrest and in undifferentiated cardiac arrest. And the thought here is that there is some sort of an improved hemodynamics with administration of thrombolytics, along with surviving longer CPR periods. And the thought process was, we know that thrombolytics takes time to work to restore TIMI flow 3, but, and they might take about 60 minutes. But even that improvement in flow that probably is so little and that restores a little bit of that flow to the coronaries would have helped. And there are a lot of studies, animal studies and experimental studies, that talks about improvement of the macro and microcirculation along with the cerebral flow improvements. So this is what was the basis. So let's talk about the evidence here. So, we know that the AHA and the ECC recommended against it or not recommended against it. They said, well, it's not something that you would consider giving on routine basis for all out-of-hospital cardiac arrest. And this is probably the first prospective study that came out in regards to administration of thrombolytics and lytics in undifferentiated cardiac arrest or in out-of-hospital cardiac arrest. So Budiger, I hope I'm pronouncing his name correctly, he actually used a historical control group, and he collected prospectively 40 patients with out-of-hospital cardiac arrest who have undergone CPR for 15 minutes. At the mark of 15 minutes, they decided to administer thrombolytics along with heparin, and after 15 minutes, if no regain of circulation, ROSC is not achieved, they can repeat the regimen in about 30 minutes. So what are the results? So interestingly enough, you can see that 68% of the intervention group had ROSC, and there were higher ICU admissions. Now these two, albeit there are very small numbers, these two indicates that there is some sort of a benefit there to prescribing and administering thrombolytics in out-of-hospital cardiac arrest, and those both were statistically significant. But bear in mind, these are very small numbers. Now, however, the 24-hour survival and the hospital discharge were not that different from both groups. Now, Fatovich said, well, you know what? Maybe it's not about how soon you give or you administer the thrombolytics. It's probably when should you give it. So what he did is a prospective randomized double-blinded study that included all out-of-hospital cardiac arrests that are presumed cardiac in nature. And what he proposed is that we want to administer thrombolytics as a first-line drug instead of even the drugs of ACLS. So, that epinephrine, that we don't know if it works or not, that toxin that it works or not, we're just going to put it aside and we're going to give thrombolytics as soon as the patient hits our emergency doors. And he had small numbers of 35. Now, again, not a lot of difference. ROSC, DC from ED or DC from hospital, we had one patient and one patient discharged from the hospital. Now, albeit that whatever numbers here you see in terms compared the treatment group versus the control group is basically probably skewed by the fact that, most of the patients were younger in the treatment group, plus they had VFib as their initial arrhythmia. So that gives you an indication that probably that's why they survived. I'm not sure. But this was not a strong study. But it's just a thought of giving thrombolytics at the offset of your ACLS in your hospital. Now, Riyad Abu Laban came later and he said maybe it's not about whether you should give thrombolytics or not. Maybe it's not about the timing of thrombolytics in terms of where should it be placed in ACLS. Maybe it's the patient group that we should be more careful about. So he selected a different group. So he conducted this randomized controlled trial, and he included PEA arrests, thinking that, well, most of PEAs probably are due to PEs, and the survivability will probably be good based on the case series that has been published over the course of the past years. Now, he had and at that time, back in 2002, this was probably the largest study of its kind. It had they enrolled 233 patients, and it was basically a negative study. Okay, he didn't find any difference in terms of ROSC, neither discharge from hospital, and a lot of people have talked about, at least 22% of his population, of the intervention population, had asystole as their first arrhythmia before actually developing PEA, and that might have contributed to bad outcomes. But what is interesting is that even his control group, with conventional ACLS protocols, they didn't have comparable outcomes as you would expect with any other group. But again, this was PEA arrest, so it just shows you that PEA arrest is not a good thing. Then come along the largest study to date, which was published in the New England Journal of Medicine 2008 by again Whitaker, the same initial group who published in 2001 their first prospective study asking this question: whether thrombolytics in undifferentiated cardiac arrest or in out-of-hospital cardiac arrest works or not. So it was a prospective. They conducted a prospective, randomized, double-blinded. It was lytic versus placebo. They enrolled over 1,000 patients and about 500 in each group. Pretty much they're similar in characteristics. There are not a lot of differences. But the major difference here, this is a multi-center study that has been carried out in Europe. And the way it went is that there was a mobile ICU that moved to the patient. They were trained and they had a clear protocol. So if that patient fulfills that protocol, thrombolytics would have been given in the scene. And mind you that over the first 3 studies, the average time of administration of thrombolytics was 35 to 40 minutes. So what these guys have done is that they managed to reduce that time down to 18 minutes. And look at the numbers. So survival, they looked at their primary outcome was survival at 30 days, and it's not different. ROSC was not different between both groups. Survival in 24 hours was not different. Admission to hospital was not different. Discharge from hospital was not different. CPC of 1 to 2 was not different. The only thing that they noticed was that people who had received thrombolytics had a higher risk of developing ICHs, which is contrary to a lot of the retrospective data that suggested that thrombolytics didn't really increase risk of bleeding much. But these guys have noted that there's definitely an increase in bleeding, and specifically in ICH. And it was stopped due to futility at one point in time because they thought it was probably not the way to go. So the question here is that, do we have enough evidence to say that thrombolytics works in out-of-hospital cardiac arrest? Well, the answer is probably in undifferentiated cardiac arrest is no, But there are specific situations where you might want to think about intra-arrest thrombolytics. And just I'm going to highlight two situations where you might want to keep them in your mind, because these are some situations that you would probably want to give it. And the AHA also kind of recommended that vaguely. So if you have a patient with pulsed electrical activity who comes in with a high probability or a definitive diagnosis of PE, so you had done an echo and you've seen the RV is blown up, or you had a patient who just came down from CT scan and there's a massive PE and then he arrests, then this is something that you might want to consider. This is a case series, a prospective non-randomized consecutively collected patients of 23 patients with included patients who had PE, confirmed PE, and developed PEA, and you can see that they had fantastic results. It is what it is in terms of evidence, but they had 95% of them regained ROSC, and about 20% had 3 months survival. 87% had a 3-month survival. Another situation where you want to consider giving or administering thrombolytics is in refractory VFib in patients who have cardiac coronary syndrome and develop cardiac arrest. This is another thing this is another case report that indicates, a patient who came in 58 and 59 years old, had a cardiac arrest deemed to be caused by coronary artery disease. They did an echo, they found hypokinesia and akinesia, they had a positive trope. After 58 minutes of resuscitation given thrombolytics, he survived 10 days. He's out of the hospital with CPC of 1. So if you want to hear more anecdotal reports, listen to what Stephen Brooks has said. He's a co-author of the 2010 AHA guidelines and ECC guidelines. And he talks about his own experience about, he's a co-author. He's one of the people who actually said it's not recommended for undifferentiated cardiac arrest, but he had different opinion at that point in time because he had a different category of patient. So you just search it. It's free online. Listen to it. It's 5 minute long. It's a nice story just to keep in the back of your head. So. Ultimately, we know that out-of-hospital cardiac arrest poses a diagnostic challenge. We still don't know who benefits from cardiac arrest. My sense, if I would face that position, someone who has PE, confirmed PE, or high likelihood of PE develops cardiac arrest, then this is probably a patient that you want to administer thrombolytics for. Number 2, someone who has coronary artery disease and you don't have PCI, or if patient is quite unstable to move to the cath lab and in VFib, refractory VFib. That's something that's to consider. There is evidence in terms of case series and case reports that supports that procedure, and the AHA says it's fine. And the timing of administration, we still don't know. The regimen or the regimen of the medications, we still don't know what works. So that's up for grabs and up for more studies. But there's a huge paucity in studies in regards to this specific question. And that's about it. Thank you.